Hello, everybody. First and foremost, thank you very much to the organisers for the opportunity to present this research at this important Congress. I feel very privileged, so thanks very much indeed. What I'm going to be doing today is giving you a brief overview of a study that we conducted which explored the use of family meetings in hospital settings in Australia. So why did we embark upon this study in the first place? What were the key reasons? Well, over a decade or so ago, we were quite interested in this area of family meetings in our clinical practice. These were seemingly commonplace, but we were somewhat surprised when we looked at the literature and we found that there really wasn't much evidence for the benefits of family meetings in terms of outcomes for patients, for family members, for the healthcare team, or indeed the healthcare service. So this was somewhat of a surprise. More recently, a few years ago, there was a comprehensive systematic review which found similar things and really confirmed our preliminary findings from some time ago. So this really was the rationale for us taking this work forward and trying to get some more understanding of what happens as a consequence of running a family meeting in a palliative care setting. So what specifically did we want to find out? So there were three main areas of focus. The first related to palliative care patients. So these were patients with advanced disease who were admitted to specialist palliative care inpatient beds at the participating hospitals, or if they were referred to the palliative care consultancy service within those hospitals. So they're receiving standard specialist palliative care plus the intervention, which in this study was the family meeting. And I'll talk about the intervention in a little bit more detail in a moment. So we wanted to know really whether or not there were any outcomes with regards to a decrease in hospital admissions, decrease in access to ED, less hours in ICU, and potentially less chemotherapy in the last 30 days of life, which we know is a quality indicator with regard to end-of-life care. So these were the outcomes we were wanting to explore with regard to patients in the study. The second area focused on family carers. So these were the primary family carers as identified by the aforementioned patients, and they received standard specialist palliative care plus the family meeting. And with regard to the family carers, we were interested in four outcomes. So our primary outcome was trying to minimise psychological distress. This is obviously a real issue with regard to the prevalence of this for family caregivers on entry to palliative care. A number of studies have shown the distress levels, around about a third of patients admitted to palliative care services, the family carers reach the cutoff for psychological distress on validated measures. So this is an area we want to hopefully address, and hence was our primary outcome. We wanted to reduce family carers' unmet needs, and that's fairly understandable. And obviously, in keeping with the tenets of palliative care, we wanted to improve family carers' quality of life. And finally, we wanted to enhance family carers' sense of how prepared they were for the role of looking after somebody with advanced disease. And this comes from the theoretical framework that underpinned the study, but also, again, just as common sense and other literature from other areas, which shows, in the most part, if we're confronted with a challenging situation, if we're better prepared for that event, then we usually manage it in a much more favourable way. The third area we wanted to explore in terms of the consequence of running family meetings is whether or not there was a reduction in healthcare costs linked to those four outcomes that I mentioned for patients. So how did we go about this? So this was what we termed a pragmatic cluster trial with 3 hospitals. It was conducted in keeping with the Medical Research Council UK framework for complex interventions, hence the kind of link to the pragmatic nature of it. And it was conducted in 3 hospitals in Australia, and one of the hospitals was randomised to the control arm, and the other 2 sites were randomised to receive the intervention. The full details of the methodology of the study are outlined in the protocol in that top paper. And the intervention itself, as I've mentioned, was the family meeting. And this is a structured family meeting. Again, the full details of the ingredients, the training, the process around conducting these family meetings is there for you to access an open access journal. But in short, these are guidelines that we published that focus on multidisciplinary palliative care family meetings, whereby the needs of the patients, the family carers, and indeed the healthcare team are considered in advance of the meeting, so that hopefully the meeting itself focuses on the priority issues for those 3 parties, and obviously with additional room for matters that might arise during the family meeting. And as we know, that's certainly commonplace that things come up as a consequence of the discussion in these family meetings. And then after the family meeting, there's follow-up to ascertain whether or not some of the actions arising from the family meeting were indeed followed up. The full details, as I said, are in that particular publication for those who are interested. In terms of recruitment and data collection, so as I said, these were patients with advanced disease who were admitted to specialist palliative care beds within one of the participating hospitals, or referred to the consultative service at one of those participating hospital teams. So the patient was screened, and if eligible and consented, they were also, it was also discerned if they're willing for their primary family carer, whoever they identified, that could be a friend or a family member, and then they were followed up to see whether they were eligible, and if so, consented to the study, ideally within a few days of admission or referral to the consult service. And then if they were involved in a hospital that was receiving the intervention, they would get standard specialist palliative care plus the structured family meeting. And then about 2 weeks later, their time 2 data would be collected, and we wanted to follow up again post-death at 8 weeks after death to see whether there are any long-standing outcomes that may have arisen as a consequence of the intervention. So what did we find out? There are approximately 300 dyads who were admitted to the study, and roughly about half received the intervention on top of standard care, and the remaining participants received standard specialist palliative care. The family carers' average age was almost 60. The majority were female at 65%, and the overwhelming majority, 90%, had a cancer, the patients had a cancer diagnosis. In terms of the outcomes in the 3 areas I spoke about, there was no impact that we could find with regard to the patient in terms of hospital admissions, emergency department presentation, ICU hours, or chemotherapy treatment. So no impact, it seems, either way in terms of either a decrease or an increase in those particular areas. In terms of the outcomes for family carers, and you might recall there were 5 outcomes that we were particularly interested in. So with regard to unmet needs, we were unable to find a significant change with regard to unmet needs, nor quality of life. And this was apparent both at time 2, so 2 weeks after time 1, 2 weeks after recruitment to the study, but also at time 3, 2 months after the patient had died. However, we were able to identify significant changes in 2 of the other outcome variables. So in our primary outcome, which was psychological distress, we were able to demonstrate a reduction in psychological distress. And with regard to family carers' sense of how prepared they were for the role, well, again, we were able to demonstrate an increase with regard to that outcome. So what does this mean, and what can we conclude from this, and what are some of the implications? So we would argue that family meetings are potentially helpful, and I'll say potentially, and I'll come to that in a minute and justify that a little bit more further. So they may be helpful in reducing family carer distress and perhaps increasing family carers' sense of how prepared they are for what is, for most family carers, one of the most challenging things that they'll undertake within their lives. So this builds on earlier work from Herbert and colleagues who looked into this kind of notion of preparedness for family carers some time ago, and some colleagues in Sweden who looked at this as well in the context of family caregiving. And so this seems to be an area that's worthy of exploration. As I said at the outset, I think there's a strong kind of theoretical rationale for this, as well as a pragmatic rationale for hopefully better preparing family carers for what lays ahead. And it also builds on some work that we've been involved with others that showed some benefits from another intervention for family caregivers in reducing psychological distress. And as I said, the rates of psychological distress are reasonably high based on validated measures. And if we can go some way as service providers, as healthcare providers, to ameliorate and hopefully prevent some of that psychological distress, then hopefully coupled with increasing family carers' preparedness and other components, then I think we can hopefully bolster family carers' resilience and potentially their capacity to maintain the role and hopefully have more favourable outcomes for the longer term, we hope. So from a financial perspective, there's a real question mark based on our study as to whether or not family meetings can actually reduce healthcare costs. Just to reiterate, we didn't show an effect here based on the parameters that we explored. So I do think there needs to be more work done in this area. We collected some other data around how long it takes to run these family meetings and some of the administrative requirements and the healthcare professionals involved in some of those costs. But I do think this needs some further in-depth inquiry before we can conclude that these are a cost-saving measure potentially for hospitals. I would love to say that this was the perfect study, that everything went really well from inception of the idea right through to conclusion. But as you all know, research is always challenging, and palliative care research particularly challenging. And this was a complex intervention, and despite us taking that sort of pragmatic approach, there were some limitations for this study that I think are really important for us to be transparent about. So the effect sizes weren't large with regard to distress and preparedness. As I said, we didn't undertake a full health economic appraisal, so the conclusions around costs need to be considered with that, bearing in mind that particular fact. The generalisability is limited. This was conducted in 3 hospitals in Australia. And we would have liked to undertake a larger cluster trial with more clusters, but we were constrained by the funding that we got for this particular project. The other area that I think is something worth considering too is a recognition that although we found significant changes, favourable changes in terms of reducing distress for family carers and also increasing their sense of how prepared they were, we don't really know how that's operationalised in the real world in terms of whether or not that had implications day to day for family carers themselves. We were unable to find any published data around the significance from a clinical perspective of changes on those validated measures. So I think that's something that should be considered in the future, hopefully. So I'd like to conclude with a question, and that is, should family meetings be standard practice for all palliative care patients and family carers, in the hospital setting? And I do think the jury is still out. The clinician in me says that, yes, they should. That's my kind of initial response. It seems to be a sensible thing to do to to offer these family meetings routinely and ideally prevent unnecessary events, and rather than wait for a crisis meeting that perhaps could have been, that particular issue could have been prevented through a family meeting earlier on. But from an evidence-based practice perspective, I do firmly believe that we do need more data. We need more empirical inquiry with regard to the impact for patients, for family carers, for the healthcare professionals that are involved as well, and also for the healthcare system as a whole. So I think until we have that complete picture, I think it probably is not fair for me to recommend definitively that these should become standard practice throughout. But I think a call for more evidence and more research, I think, is what we're concluding. I do need to acknowledge our team, and we had a fantastic multidisciplinary team from across Australia involved in this study. So I do thank them for their insights, patience, and valuable methodological suggestions and practical solutions. Research nurses who often don't get formally recognised, but these studies wouldn't occur without the research nurses. It certainly wouldn't have occurred in our particular project, and the patients and families and our funders. So I'm mindful that this has been a lot of information condensed to a short period of time. For those of you who are interested, please don't hesitate to get in touch with me. My email's there, and I mean that sincerely. But just to say, thank you again to the organisers for the invitation to provide you with a short overview of this particular research. And I sincerely wish everybody well for the rest of the conference, and thank you again for the opportunity. It's appreciated.